هذا الرجل قاعد في وسط هذا العنبر الجميل يتناول كل انواع الطعام والخضار والفواكه والنظافه وطريقه الصرف، السمك والسلم والحاجات دي كلها مصادر جيده للكالسيوم وفيتامين دي على طول عمرك. لكن في المدارس لازم تاخد الفيتامين دي غصب عنك، ولازم تاخد مزاجك، لازم الاهل يحببوا اولادهم لشرب الالبان وقت البيض الصبح عشان يبقوا مبسوطين، الاب والام والجد والحفيد والحفيده. تتمتع السيدات الحوامل بالشمس والضوء والهواء وتعيش حياتها طبيعه وتنطلق وتلعب رياضه حتى المخ يبقى متوازن، تعمل كل شيء جميل في حياتها وتستمتع بها الاحفاد والاولاد في مرحله جميله. كالسيوم اند فيتامين دي ريفولوشن حقا انها ثوره محتاجه الى ان ناخذ شمس ونروح كلنا في الصيف على البحر نستمتع بهذه المركبات من فيتامين دي بكل انواع الخضار والفواكه والمنتجات لنعيش فيتامين دي بكميات كثيره جدا من الشمس. ليست العمله دولارات ب 7 جنيه ونص فقط، لكن ايضا استثمار الصحه يساوي ملايين الدولارات. اللي هتجيب الدولارات هي الصحه الكويسه، لكن فيتامين دي ده وقارنه بالذهب والعمله. واحد يقول لك انا اديني ذهب وعمله وسيبني مش عايز فيتامين دي زي بعض، اوزنها تاخدها كالسيوم تاخدها فيتامين دي، انت ايه بينك وبين اللي هي العدل. اشكركم جميعا. البنوته دي وانا بشكر شركه بيك فارم على حسن اختيارها لهذا المنتج. وهو ما اعرفش اللي يسموه شوكولاته ليه. الشوكولاته دي مليانه حاجات. الشوكولاته يقول لك ايه؟ دي قطعه شوكولاته بالليل تخلي الحب يزيد. قطعه شوكولاته تنام مبسوط، ايفوريا جيده، وايضا غنيه بالكالسيوم وفيتامين دي. شكرا.
نشكر دكتور صبحي على البرزنتيشن الجميله كالعاده، اللي هي دايما بيمتعنا بالصور والالوان والافكار، ونشكره على هذه البرزنتيشن اللي دايما بتصعب الامر بالنسبه للي هيقدم البرزنتيشن بعد.
بعد اذن بس الدكتور ماجد والدكتور صبحي، من اول دلوقتي الوعد اللي وعدنا حضراتكم بيه ان اليوم كله هيبقى فيه مفاجآت. قبل بس ما اقول المفاجأة اللي يمكن ان شاء الله دلوقتي اظن ان هي هتبسط ناس كتير، احتاج بس اسمع من حضراتكم كده ان احنا كلنا تقريبا بنحب الشوكولاته. تقريبا كلنا بنحب الشوكولاته. بس مش كل الشوكولاته احنا بنحبها. اذا في شوكولاته كده هي دي زي المولود العزيز على قلبي، في شوكولاته عزيز على قلبي. وحضراتكم عارفين كويس كمان ان الشوكليت بالنسبه لكل اللي بيحبها السبب من اسباب البلاجر، هي اللي بتدخل السعاده على الانسان. وبسبب الكاليبر that different calcium chocolate chewable fat. وده دكتور المولود الجديد هو اساس من ميلاده ان هو يعمل لحضراتكم ده بلاجر. عارفين ان من اسباب البلاجر ان ممكن اثنين من الكابلز اللي قاعدين معانا دلوقتي حتى لو في واحد منهم موجود، كيس كابل معزومين من شركه بيك فارم على رحله لمده 4 ايام 3 ليالي في احد المنتجعات السياحيه في الغردقه. عارف حضراتكم وانتوا داخلين كده بعد الشوكليت فاونتن كنا بنكتب اسماء على كاركتر صغير. يمكن في تيم من حضراتكم سالوني ايه الهدف منه. دلوقتي احنا هنعمل السحبه الاولى على سعيد وسعيده الحظ ده الكابل اللي ان شاء الله هياخد البلاجر من الكاليبر زي ما كان الشوكليت سبب بلاجر لناس كتير. كمان اظن ان البلاجر هتيجي من خلال اللحظه. هياخد البلاجر اللي داخل دي زي ما هياخد البلاجر فكره يعني الهديه دي انا عارف ان انا اول واحد باصص فيها. انا اول واحد. ان شاء الله تخرج الدعوه بألف سلامه. اوعدكم تاني استحملوني في الكلمه دي لغايه اخر لحظه في الميتنج. في حاجات انا نفسي مش متوقعها. اوكي؟ استاذن الاستاذ الدكتور ناجد يقدم.
طيب طبعا الناس محتاره وتفكر في المفاجآت المنتظره، ما حدش يعرف يركز في المحاضره اللي جايه. لكن طبعا انا يسعدني ويشرفني ان انا اقدم دكتور احمد سكتوري، هو هيد اوف جايني اونكولوجي مينيمال اكسس اند روبوتك سيرجري يونيفرستي هوسبيتال اوف ساوث مانشستر. طبعا هو غني عن التعريف برضه، وانا اول مره اقابله ويسعدني ويشرفني ان انا اكون موجود معاه هنا على الستيج. وكانت البيبرز اللي بنشرها والفيديوهات اللي كنا بنقراها له كانت من ضمن الحاجات اللي هي فيري انترستنج بالنسبه لكل الناس اللي هم انترستد في الجايني اونكولوجي. دكتور احمد اتكلمنا عن البوردر لاين اوفيريان تيومرز كونتمبرري ريفيو.
شكرا دكتور ماجد ومتشكرين لإيكو فارما على الانفيتيشن. We'll go straight into the subject, and I'm going to give you an overview of borderline tumors and its management, about its pathology, genetics, risk factors, treatment options, outcome prognosis, and follow-up strategies. No undisclosed interests. It was first discovered of the 20th century, recognized by the FIGO and WHO as a separate entity from ovarian cancer. But regardless of that, it's actually classified in the International Disease Classification together with ovarian cancer, but it is not cancer, and it largely behaves as benign. It has got the same staging as ovarian cancer. There is stage 1, stage 2, 3, 4. FIGO staging of borderline ovarian tumors, and this is where sometimes the confusion comes. Is it really that bad to be classified and staged the same way like cancer? You can have borderline tumors that send disease deposits outside the ovaries, and when it sends disease deposits outside the ovaries, we do not call them metastases. Okay, they are called implants. And even if the implants are, invasive implants, i.e. they breach the basement membrane like cancer, we don't say it is metastasis or cancer, we call it invasive implant. And if it is not invading the basement membrane, we call it non-invasive implant. So you can have a primary disease that sends disease deposits somewhere in the abdomen, and still the primary disease is not cancer, it's borderline, and the disease deposit is not called metastasis, it's an implant. We can have abnormalities in the lymph nodes whereby the cells are not normal, they look atypical, and we don't call it lymph node metastasis, we call it endosalpingosis. Serous borderline tumors, they are the majority of borderline tumors. You can get it bilateral in 50% of cases, and 70% of it stage 1. And the next category are the mucinous ones, and then rare types, as you can see. What I want to say here that 10% of the mucinous borderline ovarian tumors, which is 1 in 10 mucinous tumors, might not be primary ovarian tumors. Could be a metastasis from a colorectal cancer. And the colorectal cancer could be hidden somewhere in the appendix, which might look normal, or the colon, which might look normal as well. And I would suspect that if I find a bilateral mucinous ovarian tumor. Mucinous ovarian tumors, as you can see here, actually in this slide still, is 8% bilateral, so the majority are unilateral. So if we find bilateral mucinous tumors, and you can actually characterize them on the ultrasound scan, and they have a characteristic look on the MR scan, then you have to question, do I need to do upper GI endoscopy, lower GI endoscopy, or should I take the appendix out when I do the surgery? We normally take the appendix out in mucinous tumors these days anyway. Serous borderline ovarian tumors, they are 50, as I mentioned, 50 to 65%, as we mentioned in the last slide. But what I wanted to stress on this slide, and this is perhaps one of the most important slides in this presentation, the serous borderline tumors are two main types. The typical serous borderline tumor, which is 3/4 of the cases, 75%. Each 10 cases, maybe 7 out of 10. That's typical. And they generally behave like benign. You take a tumor and usually the recurrence is very rare. But there is a subtype which is about 1/4 or 1/3 of the serous borderline tumors called micropapillary borderline tumors. And this is why if we get a pathology report after taking a cyst out and the report says this is a borderline tumor, serous or whatever, we need to ask, is it serous typical or serous micropapillary tumor? And we'll know why now, because the micropapillary serous borderline tumor, people actually still don't know, is this a borderline tumor or is this a very, very low grade cancer? We still call it borderline tumor, but it's higher stage. It's not like the usual borderline serous tumor, like 75% or 80% stage 1. It's higher stage, stage 2 or above. It's invasive implants associated with invasive implants, and that explains the higher stage because it sends deposits outside the ovaries, and also because it's ectophytic, i.e. you open the abdomen and you find that it's not a smooth ovarian cyst, it's the cyst in the ovary with lots of vegetations and deposits outside on the outside surface, and it looks really like as if it is cancer. And it is bilateral, the majority of cases. But the primary tumor is not reaching the basement membrane. Actually, there is an allowance of few millimeters, less than 3 millimeter reaching, which is called microinvasion, and still is called borderline tumor. And these implants, which are invasive, they are actually frankly invasive. And if we look at the invasive implants, which is predominantly in that micropapillary serous borderline ovarian tumor, we find that the survival is 60%, i.e. out of 10 patients, 4 will die from this borderline ovarian tumor. And that's actually the same survival like low-grade ovarian cancer. Usual borderline ovarian tumors, stage 1 you get survival more than 95%, stage 2 to 3 with non-invasive implants, you get a very, very good survival. Out of 10 patients, 8 or 9 patients will survive. So it's very good. But if the type of this borderline tumor is micropapillary, which shows the invasive implants, survival for this stage is about 60%. The mucinous borderline ovarian tumors, which is again, the majority are unilateral, only on 8%, so less than 1 in 10, or 1 in 10, bilateral. 10% might not be primary ovarian. They have intestinal type, which is the majority. You can get ovarian intraepithelial neoplasia. That term has not actually taken off, so it's not commonly used. Microinvasion you can get, and this is actually why a specialist gynecology histopathology consultant or subspecialist in gynecological oncology pathology is important, because you can see an ovarian tumor that is mucinous borderline, and the abnormal cells reach the basement membrane. So then you tend to say it's cancer then if it's reached the basement membrane going into the stroma. But in fact, no, there are characteristics in it that you have to find it, to satisfy it, to call it cancer. You can get still borderline mucinous ovarian tumor with microinvasion up to not only 3, up to 5 millimeters of the basement membrane, and it is still borderline. And the prognosis is excellent. Excellent. So if we do a cyst, take a cyst out, and it's borderline mucinous tumor with invasion of the basement membrane, we should not overreact and say, oh, we have to go back in and take the ultrasound and the other ovary. Because you can still do fertility preservation, and you have an excellent prognosis. So that's the microinvasion. Endocervical type, Mullerian or mucinous type, and that's a rare entity of the mucinous borderline ovarian tumor. Actually understanding this histology or histopathology of borderline tumor is really of paramount importance. And that will allow us to conserve fertility in managing these patients if they are young in the reproductive years. The mucinous borderline ovarian tumors generally better if we really are sure that they are primary ovarian. As I mentioned, 10% of the mucinous borderline ovarian tumors are not actually ovarian. They are secondaries from the colorectal cancer, and they metastasize to the ovary in the form of a borderline tumor. So the ovarian tumor is not, it doesn't look like cancer, it looks borderline. And that's usually if it is bilateral. And that's what causes the pseudomyxoma peritonei. So the pseudomyxoma peritonei is not a mucinous ovarian tumor. Pseudomyxoma is a colorectal tumor, usually a appendiceal tumor or a cecal tumor, and sending metastasis to the ovary and obviously causing the problem of mucinous ascites. Can borderline ovarian tumors develop to ovarian cancer? Yes, it can, and this is a new theory now. Ovarian cancer now is thought of as two types of ovarian cancer. A low-grade ovarian cancer that actually arises from a borderline cyst, following the multi-step theory, like the development of colorectal cancer. You get a benign polyp first, and then a polyp with atopia, and then the typical polyp becomes cancerous polyp. So you get the low-grade, the type 1 ovarian cancer, typical serous borderline ovarian tumor becomes the micropapillary type, which is the vicious type, and that straight forms the low-grade cancer. And the median age, you get it a little bit lower than the high-grade, the type 2 ovarian cancer that starts straight away as cancer. And the genetic mutation, the high-grade ovarian cancer, the usual type, which metastasizes and usually is diagnosed at stage 3 and above, you get the P53 mutations. The other ones, you get the KRAS and BRAF and other mutations. Risk factors, these are the risk factors that we know of. We know about risk reduction in parity breastfeeding and aging on our there's a neutral effect, and these are doubtful still. The presentation is usually presented as a cyst or incidental finding on scanning for other reasons like fertility investigations or so. You find a cyst in the ovary that looks abnormal, and usually the mucinous ones will look, and the serous ones in the early stages, a cyst that could be unilocular or septated with some vegetations inside. If we do CA125 in a young girl, that could be misleading because CA125 can be raised during normal periods, during menses, during so many conditions that could be benign disorders, not necessarily malignant. And if you look here, ovarian cancer is only one category of all these conditions, so it's not informative. Ultrasound scan and scoring that CA125 is very good, sensitivity of about 85%. I would say the best thing is really ultrasound scan. You can do the CA125 as a baseline marker to guide you in the diagnosis. This is a typical look of a mucinous borderline ovarian tumor. You get a nodule which is a honeycomb nodule. I'll go through the presentation quickly now because of the time constraints. The mucinous tumors particularly, they can grow really large, and you can get a cyst that's from the pelvis up to the deep sternum. And it looks like that. That's usually a mucinous tumor. Um, you can get features of borderline tumors that resemble a benign cyst on imaging. It's not uncommon. Also, 13% of invasive lesions are unilocular. You can get unilocular cysts with some solid vegetations, still could be malignant. In women less than 40 years, one-third approximately of suspicious ovarian tumors are borderline. So if in a young lady less than 40 years, if you get really a very abnormal looking cyst or tumor on imaging, this could still be borderline. It doesn't have to be really cancer. So we really need counseling, informed consent, fertility, other wishes. They might not want to preserve the uterus and other ovary for fertility, maybe for hormone production, or maybe just it doesn't want to let go with the uterus and other ovary. So there's no point in forcing patients to have a hysterectomy and B. So if we know what is the outcome depending on the type of the borderline we are managing. If we are suspecting a borderline ovarian tumor based on imaging and a young patient, we can prepare the patient on two-stage surgery. We go first and take the tumor, and depending on the final histology, we can decide what to do first, next, and what to do next could be done laparoscopically, not necessarily another open surgery. Frozen section can be used, although it's got its positives and negatives in that. So about 95% agreement, 84% agreement with diagnosis of borderline ovarian tumors, but this is in the small tumors. But in the large tumors, actually the sensitivity and specificity goes really down. Careful inspection of the entire abdominal cavity, taking the ovary and the cyst. I'm going to give you some percentages of recurrences in a second now. But again, I want to stress that micropapillary borderline tumor, this is the only one thing that we need to establish when you get a histopathology report saying that it's a borderline ovarian tumor. Is it a micropapillary one or not? And this is only because of this. Limited staging, i.e. removing the cyst or the ovary, not necessarily the tube. If the tube looks perfectly normal, you can leave the tube because it can pick up an egg from the other ovary. And then you take the samples and washings and take omentum and all that. No need to take lymph nodes in borderline ovarian tumors. We only take it in apparently early stage ovarian cancer. If we take a cystectomy, unilateral salpingo-oophorectomy and bilateral salpingo-oophorectomy and hysterectomy, this is a study done on 168 patients looking at the outcome of several different management strategies. I want you to look at laparoscopy versus laparotomy here, and that's recurrence 14 versus 17%. So you're not compromising borderline tumors by laparoscopic management, but we only do that in the small lesions, not in the large lesions. Okay? And this is an important one, looking at the recurrence. If you do cystectomy, 1/3 will recur, normally recurs as borderline tumors, and then you can take the cyst again. Do unilateral salpingo-oophorectomy, 1/5 will recur, take both ovaries and 6% will recur. In general, stage 1 recurs in about 1 to 2 in 10 patients, so it's not a high risk, and if it recurs as borderline again. This is except, again, the micropapillary borderline tumors, because we cannot guarantee it will recur as borderline. It can recur as low-grade cancer, and the patient has to know that. This is looking at the recurrence, ipsilateral recurrences, cystectomy, unilateral salpingo-oophorectomy, and B. So ipsilateral, if you do only cyst, take the cyst out, you get 41% ipsilateral recurrence, 25% contralateral recurrence. That's within the context of the recurrence, which is only 2 to 3 in 10. Okay, so the majority of them will be ipsilateral. So conservative management high stage, yes, you can do conservative management in the high stage, except the micropapillary borderline. So everything you find that I'm talking about micropapillary, excluding it from the good prognostic ones. Okay? because the recurrence in the invasive implant, which is usually with the micropapillary, 66 to 70%, so the majority will recur, and again, we cannot guarantee they will recur as borderline. They can recur as invasive hairs. Laparoscopic conservative management, if the cyst is of a large number, more than 5 centimeters, you get cyst rupture, incomplete staging, and disease recurrence. Mucinous borderline tumors are normally larger than 5 centimeters when they are diagnosed, but in fact, actually, this mucin, if it is primary ovarian borderline tumor, that mucin or that jelly-like stuff inside the ovarian cyst is acellular. And you find the histopathology report coming back as acellular mucin, and that's fine. The prognosis is still excellent. They do very well. If it is obviously secondary tumor, the prognosis is grim. I will just skip this. How can we predict prognosis for borderline ovarian tumors? There has been some studies on ovarian ploidy, still ongoing every now and again. Reproductive outcome, favorable outcome, effect on fertility drugs. There is no effect on fertility. You can induce borderline ovarian tumors if they are truly borderline ovarian tumors. Pregnancy does not have a measurable effect on recurrence at all. Age at initial management is the main determinant of fertility outcome. So the age of the patient really is the main determinant of that. Crowd preservation, I will leave that issue because it can be done, but still depends on the expertise in the center. There is no place in adjuvant treatment for borderline ovarian tumors, i.e. chemotherapy, apart from the micropapillary borderline ovarian tumors with invasive implants. Still debatable. For example, the center where I work, if we do complete cytoreduction, i.e. no residual disease, we do not give chemotherapy because we believe that it's not actually responsive to chemotherapy for that. How to follow them up? Long-term follow-up for high-risk groups. The micropapillary one, the conservative surgery one, i.e. the ones that you remove only a cyst or an ovary and left the other one, and the ones whereby a cyst was removed as assuming it is benign and turned out to be typical, not micropapillary, typical borderline ovarian tumor. Just you need to keep an eye if you're not going to laparoscopically stage her, and the suboptimally site-reduced ones. We follow them up with ultrasound scan in the pelvis. All recurrences, even if distant recurrences, they have to have, or they were found to have a recurrence in the pelvis. So we start with the pelvis. If there is recurrence in the pelvis, we look all over the abdomen every 3 to 4 months. And this is as long as they have the other ovary and uterus. If you've had a definitive surgery, 5 years is enough. Other cancers like colorectal cancers can be associated with a previous history of borderline ovarian tumors. BRCA1 and 2 mutations is not a feature of borderline ovarian tumors, and that's a good thing to know, because if you're treating young patients from borderline ovarian tumors and you did a hysterectomy and BSO, you can give her HRT and not subjecting her to excessively increased risk of breast cancer because she will need something to protect her bones. And that's the conclusion, which is basically what we've mentioned. I really want you to remember the micropapillary borderline serous ovarian tumors. That's one thing.